Well, hello everyone. Welcome to our latest Carnal Farrow podcast. And today I'm pleased to be joined by Siva Anandaciva from King's Fund and also formerly from NHS Providers. And also have Bev Evans, who is Head of Finance and Productivity, also the Deputy Chief Executive at Carnal Farrow. And today we are talking about the topic of productivity and going to get some views from both of you in terms of what you're seeing at the moment. And I thought just as a sort of starting point, I was interested to get into your general views on the challenges of productivity as a concept for both systems, but also for individual providers and what you think about that. So maybe Siva, if you'd like to kick us off and we'll see where we go.
Wow, thanks. Great question. I suppose one of the challenges is productivity is a really technical and technocratic construct, isn't it? I mean, because productivity, to me, is equations. It is how your outputs are growing, things like A&E attendance. There's all the things you want a healthcare system to produce, how they're growing compared to how its inputs are growing. Things like staffing, equipment, all the things you need to produce those outputs. And I've got to say, I'm yet to sit in a room in the NHS where you talk about productivity and people's eyes light up. And I think partly that's because it doesn't quite feel real. It feels slightly removed from their day-to-day existence. If you talk about things like waste, if you talk about things like efficiency, people light up, but productivity is a slightly cold concept. And the other challenge, I think, is despite you can say it till you're blue in the face, but I think when people sometimes hear poor productivity growth in the NHS, what they hear is people aren't working hard enough. And those two things are very, very different, but I think unfortunately just become entwined, enmeshed, and almost toxified.
I completely agree with you, Siva. I think you mentioned waste, and I think a lot of the times when having conversations with people sort of on the front line, those working in wards, working with clinicians, operational managers, if you talk about, reducing the waste and actually thinking about much more of getting it right first time, so that you're actually optimizing both the patient's experience, the staff experience, and everyone else working alongside, then actually people can resonate with that much more. Whereas otherwise, I do think productivity has become a bit of a dirty word in terms of actually, compared to what you were doing pre-pandemic, you're not working as hard is definitely how people are feeling it much more. So I think that's one of the biggest challenges actually, is in terms of actually how you engage people, Phil. I think in terms of actually thinking about, this is about doing the right thing as opposed to you're not doing enough.
Yeah, I've had a few places I've worked with where people have actually said to me directly, the best way to ask people about this is to walk into frontline environments and say, well, how could this be better? Because a lot of the things that people come up with would result in better productivity in a measurable sense, but actually the way you engage with people, I think, is really important. From what I've seen. I guess the other one.
And sorry, Phil, just to say,
Yeah.
I think that's a really good point, because I think again, productivity, you can try and adjust for things like quality, and we do. But fundamentally, you are talking about producing outputs, you're producing activity, you're producing things. And I think if someone asked me the question of how can I make things better, I'd be thinking about, well, what's adding value to patient care, which is not always doing more. It's not always bringing people in and out as quickly and efficiently as possible. It's things like perhaps longer consultations to really understand what would add value to their health and well-being, and different interventions, which may not always show up in productivity measures. So I think that's a really powerful question that you're asking when you go to the front line.
Yes. Yeah. And then
I think that for me,
yeah.
I was just going to say that for me it's really thinking about what are the right KPIs then as well, when you're on the side of actually, you do want to demonstrate this and you do want to be able to measure it in some form, but actually thinking about what are the right KPIs is really key. So that it comes back to the engagement point, but also the sustainability point, because at the end of the day, I think that's one of the things that we've seen is that people seem to have, they are working so hard, but they seem to have lost the sort of the way of thinking of the sort of the core controls, in terms of actually, ordering things, procurement, thinking about, do I need this extra test, or actually is this blood test already been done in another part of the hospital before they came onto the ward as an EG?
Yeah, and the other area that we've worked in that's always quite a hard circle to square or square to circle, whichever way you want to look at it, is when we're talking with commissioners, they'll often talk about the need to find ways to get more resources in the community settings to be able to alleviate pressures on acute providers, for example, but also because it's better for patients in most cases to have care closer to home. But contrasting that with provider views of being under so much pressure and thinking, well, how could we think about releasing resource to be able to enable that to happen? And I don't know if you have a view, Siva, on how some of those things could possibly be squared off, or what you think should be done about it.
Do I have a view on one of the great policy questions of
Yes.
our time? I mean, that's the big, and to be honest, it's such a familiar problem, isn't it? It's one of these things where moving care into the community or shifting the balance of care, as someone said, if it was easy, we wouldn't be talking about it so much. What I would say is, I'd say a few things. First of all, it's absolutely the right thing to do, and I think it's worth reaffirming that shifting the balance of care towards a more preventative focused system where care, where appropriate, can take place outside of hospitals and does so. Yes, community diagnostic centres, you name it, all of that, yes. The second thing is we just have to, back to Bev's point about KPIs, we have to be really clear about what we're expecting. If we do that, I'm not necessarily expecting costs to reduce overall in the healthcare system. You might improve value and the outcomes you generate for a given set of inputs. But I think if we're doing it to save money, there's very weak evidence that moving care into the community saves money. So let's do it, but do it for the right reasons. And the third thing is, I mean, the reality check is I don't see in the next 5 to 10 years a financial or fiscal environment where there's enough money to parallel run systems. So I think we are in the space of trade-offs where we will move care into the community, but it will come at the expense of care that could have gone into the acute sector, and that will absolutely have a knock-on impact on waiting in the short term on waiting times. So I think it's in the old days it was called differential growth. Money was flowing into the system and you could grow community care faster than you were growing acute care. I think we're right at the limits now. So politicians talk about tough choices. That's your tough choice.
Certainly a courageous area to be making decisions on, isn't it?
Yeah. But one thing I'd say that makes it less courageous is if I was speaking to a politician, I'd say, but look, you can keep running the old system, and I'll tell you what, month in, month out, you'll be hit for A&E performance and elective waiting times and all the rest of it anyway. There's simply not enough hospital capacity, even if all the investment was going into it, to meet these targets. So you might as well use that opportunity to reshape the healthcare system.
Otherwise, you're just not going to move forwards. It's just going to be perpetuating the problem, which is, as you say, the reason why we're talking about it is because it's not an easy thing to do. I just had a couple of thoughts from work we've been doing relatively recently, just to add to that, which is if you think about it in terms of population health management approach, and actually really who are the people in your population that you want to be targeting to make sure that you do get the best. You mentioned value add, Siva, and we've been doing some work with the NHS Confederation, which fundamentally started with showing that if you do invest in health, then you do get a return, and it really improves sort of the GVA in terms of the wider population. So for every pound invested, our analysis identified that gives you a £4 return. If you actually invest that growth money into community and out of hospital services, that return isn't just 4, it's 14. And it just shows that if you look at the right interventions, and this isn't about applying just a massive blanket approach, but really focusing those interventions. So if your population is, suffering with obesity, or the issues are actually to do with homelessness and housing, or actually it's families that you need to identify that they're just not getting, they're worried about being able to feed their children, and they've got multiple long-term conditions, and you've got a myriad of different factors, including mental health issues, all going on, and you can actually get behind those and focus the interventions to support the family in a much more cohesive way, then actually that's going to give you a much longer term sustainable benefit and improvement that actually really demonstrates that return on that investment. But it does mean we can't be short-sighted. We can't be thinking just in terms of a year. And actually, we do want to make sure we're reducing waste in hospitals. But your point that you made about the challenge to politicians around, but let's then think about, you're not going to make the situation perfect in the acute sector. So let's think about where is the best investment to be made. And I completely agree. I think that is focusing on actually, an efficient way of investing in the community, so that you're really targeting those and using that population health management approach and thinking about the data environment whereby we can actually identify the people. Where this works really well is when you actually basically can get the phone number of the person that you need to support.
Yeah, I completely agree. And I'd just say that, for anyone who's sat there feeling really nervous about this, I'd say, first of all, this doesn't take the heat off a hospital or any individual unit in a healthcare system from being as efficient and productive as it could be. If your job is to run a cataract service, your cataract service should be as efficient as possible. But I think the second thing is what Bev was articulating there really helps, because if you think that population health management is in some way soft or woolly or not as real and serious as labour productivity in a hospital, my goodness, I mean, what you're describing there is basically a smart healthcare system that knows exactly where its need is, how to target resources to tackle that need, and is using its overall global resources as efficiently as possible. You'd expect that in the private sector, you'd expect that in the public sector, and the NHS should be no different.
I completely agree. And I think the other thing is that, we've got so many new opportunities coming through with the increased use of AI. Technology has always been something that has been game changing for the NHS, moving from the ability to just do X-rays through to CTs and MRIs as an example. But what the NHS is really bad at, is actually not doing some of the lower level things, because actually the more advanced technological solutions give you the same answer. But what we do is we do both. So we just add cost in terms of doing that. And I do think we really do need to think about how we use our data environment to really drive efficiency and reduce waste, and how we use things like the advancements around AI to support a lot of this. And that's really difficult because people are really frightened that actually that means they're going to lose jobs, there's going to be less requirement for some of the staff. But actually it's about, we know that actually workforce and the ability to recruit staff is one of the biggest challenges the NHS faces. So if we can focus people's minds on thinking that this is about actually having people doing the jobs that add most value, where they can't be replaced by something else, then actually that's the way to think about it, rather than actually this is a scary new technology that is basically going to make you all redundant.
Yeah, I agree. And I do feel for people who think the robot's coming for them. I'm old enough that when I started my career, my boss would see email as a new thing and would talk wistfully about the typing pool he used to have in the civil service. And so there is this change resistance. But at the same time, I mean, the difference between, again, I'm old enough that my parents used to work on X-ray film. The minute it goes digital, you open up opportunities for asynchronous reviewing a film, faster turnaround times, better image resolution. And the other thing I'd say is, if I was to pull out the prescribing manual for medicines in this country, it's about 3 inches thick. There is simply no capacity in the human brain to hold all that and the contraindications. What this new technology can do, if we get it right, is support people to make better decisions rather than taking decisions away from clinicians.
Yeah, and actually hearing what you're both saying on that topic, it's probably a really good opportunity there for systems or ICBs, as well as things like provider collaboratives, to think about how do they create those environments, whether it's data sharing or creating platforms, etc., for individual providers and teams within providers to be able to work and do things differently. So there's actually quite a lot of opportunity, I think, in the system space to help unlock some of this.
It's quite an exciting time, really, if you actually think about it. But you can equally see how for many people it's also quite scary and daunting. And I think that's why we have to be really working with people. It comes back to the point we started the conversation with around engagement and actually, really understanding what's going to make this better for you. I think your point, Phil, where you said at the start, how when you're talking to people on the grounds, when we're trying to help people solve these problems, it really is, what's going to be the thing that makes your day better.
Yeah, absolutely. I think when it comes to systems of care, there are opportunities in terms of basic operations and scale, reducing duplication, having consistency in everything from, the classics of back office and procurement practices, all of those things. There's a second thing which is more transformational and links to what Bev was talking about, where it is a fundamentally different proposition to be a hospital or a primary care practice serving your client base to suddenly being part of a system that is accountable for the health and well-being of a local population. So it opens up opportunities around population health management. In all of that, though, I think it's easy to disappear into the ether of organograms. I think Bev makes the critical point at whatever system you're working in, however we organize a health and care system, at some point you have someone who is providing care and someone who's receiving care in a setting together. And unless you get that interaction right, unless all the incentives are in place to support that sort of interaction, you're not actually fundamentally changing the model of healthcare you want to deliver.
Very interesting. And obviously lots of things you could do at system, provider collaborative, ICB, and organisation and team level throughout this whole thing. So it really is everybody in it together to try and figure out how to harness the opportunities that are actually already there with the resources that exist. So I guess just for me, before we sort of close, just either of you have got any sort of top tips on what you think people should be thinking about from anything that we've spoken about today, or takeaways?
So for me, the top three things would be: think about the language that you use. So, make it something that's positive about getting it right first time and reducing waste, as opposed to, so think about carrot rather than stick, I suppose, is what I'm saying there, is actually this is about making things better for people. Secondly, and it links to that, it really is about the engagement. Ask people, get them involved, don't dictate from the top. So, these things don't change. So you can issue an edict, and as a former finance director, I'd have financial controls in place and standing financial instructions. If you didn't actually have those understood and really mean something to people on the front line, they weren't going to be following them, not because they didn't want to, not because they were being particularly difficult, but because they didn't understand them. So that's really important in terms of making sure that you're engaging them. And then finally, I think about this use of data and the use of technology, and sort of how do we actually make that to best effect, and again make it something that can actually make people's work lives, patient experience, and the whole interface between clinician and member of the public better, is really important, and we should be embracing it, albeit that it can be a bit scary. And again, reflecting, I'm old enough to recognise a lot of the things you were describing, and probably some more than you were, Siva, but I'm sure you've got some other things to add.
Not that many. You've which is a good thing, I think, that we're aligned on, we have different experiences, different perspectives, but if you'd asked me to give a list of three, I would have given exactly the same list, which I think says something. If I was forced to pick something unique, the only thing I'd say is I believe in systems of care, networks of care, but I think they've got to really demonstrate to clinicians, to politicians, to patients and the public, how have they made things better? So do the long-term strategic thinking, absolutely, but have a very, very early story to tell. I don't mind if it's a shared staff bank or road to design or whatever it is, but have something to say of, we're an integrated care system, we're a provider collaborative, and here's something that exists that didn't exist before, and it's made people's lives better.
Great, appreciate that, Siva. It's a nice note to end on in terms of doing a little bit of transformation today that's going to help with tomorrow. So very much appreciate your time, both of you, and thanks very much for having us.
Thanks, Phil.
Thank you. That's been really interesting.